Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the April 2026 issue of the journal Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes, I'll provide a brief overview of key manuscripts published in each of our content areas. First is our asthma section. Interleukin-5 may contribute to airway remodeling in severe eosinophilic asthma. In this issue, Taylor and colleagues report findings from a prospective cohort of 37 patients treated with mepolizumab for severe eosinophilic asthma who had bronchial biopsies at baseline 6 and 12 months into treatment. The study was designed to determine if mepolizumab, an anti-interleukin-5 antibody, can modify airway remodeling in adult patients with severe eosinophilic asthma. Treatment improved asthma control, reducing the number of exacerbations, oral corticosteroid courses, and hospitalizations. There was a reduction in reticular basement membrane thickness, airway smooth muscle mass, and proliferating cell nuclear antigen positive airway smooth muscle cells in the bronchial mucosa. Blood eosinophil counts decreased, and eosinophils were almost completely depleted in bronchoalveolar lavage fluid at 12 months. These findings show that mepolizumab may attenuate structural airway changes in addition to its anti-inflammatory effects in people with severe eosinophilic asthma. Completing this section is a Chest narrative review on the application of precision medicine to the heterogeneity of asthma attacks. Our chest infections content area is next. The role of fungal sensitization in bronchiectasis is poorly defined. In this issue, Tew and colleagues report findings from an international multi-center evaluation of 277 individuals with bronchiectasis from 6 tertiary centers in 4 countries. The study used a comprehensive, expanded allergen panel with 11 crude and 24 recombinant fungal allergens to determine the prevalence and clinical implications of fungal sensitization in bronchiectasis. Sensitization to recombinant Aspergillus fumigatus was associated with bronchiectasis severity, including severe exacerbations. The association was strongest amongst those with low baseline exacerbations. Sensitized low-risk individuals had greater disease severity and a higher occurrence of bronchiectasis COPD overlap than non-sensitized low-risk individuals. Polysensitization to the same allergens conferred further additional risks of severe exacerbations. These findings identify Aspergillus fumigatus sensitization, particularly allergens 12, 15, and 17, as a clinically significant trait in bronchiectasis. Also in this section is an original research article that explores structural and functional pulmonary MRI to predict pulmonary exacerbations in cystic fibrosis, and a Chest narrative review that examines the threat of H5N1 highly pathogenic avian influenza to human health. Our COPD section is next. Disease stability is a proposed COPD treatment goal, but its clinical significance is uncertain. In this issue, Sun and colleagues report findings from a nationwide prospective cohort of 1,639 patients with COPD in South Korea, 147 of whom, or 9%, had achieved disease stability. Disease stability was defined as having no moderate or severe exacerbations, no decline in post-bronchodilator FEV1, and no deterioration in health status during the first year after the baseline visit. The study was designed to determine if there are differences in lung function decline, exacerbation risk, and mortality between patients with COPD with and without disease stability. Those with disease stability had lower rates of moderate to severe exacerbations. The annual decline in FEV1 was actually greater in the disease stability group, while disease stability was independently associated with a significantly reduced risk of all-cause mortality. These findings show that patients with COPD and disease stability have reduced exacerbations and mortality, supporting disease stability as a meaningful treatment target. Next is our critical care content area. In preterm infants receiving non-invasive ventilation, data about inspiratory effort and transpulmonary driving pressure are scarce. In this issue, DeLuca and colleagues report findings from a pilot prospective observational cohort study designed to evaluate the characteristics of inspiratory effort and transpulmonary driving pressure in extremely preterm infants undergoing non-invasive ventilation. Measures of electrical activity of the diaphragm were used to estimate inspiratory effort and transpulmonary driving pressure. 10 patients with respiratory distress syndrome, 25 with evolving bronchopulmonary dysplasia, and 5 control term neonates were studied. Interpatient variability of inspiratory effort was higher in patients than controls. Breaths with inspiratory effort greater than 10 centimeters of water occurred more often in those with bronchopulmonary dysplasia than respiratory distress syndrome and control infants. Breaths with transpulmonary driving pressure greater than 20 centimeters of water occurred more often in those with respiratory distress syndrome and bronchopulmonary dysplasia than controls, and correlated with a degree of oxygen impairment. These findings help to characterize inspiratory effort and transpulmonary driving pressure in preterm infants receiving non-invasive ventilation. Completing this section is a consensus statement that describes challenges and recommendations for integrating circadian medicine into critical care. On to our diffuse lung disease section. Serious side effects from immunosuppressive agents and tumor necrosis factor inhibitors used to treat severe sarcoidosis have not been compared. In this issue, Chow and colleagues report findings from a retrospective analysis of data from the TriNetX research network covering 2012 through 2023 across 82 health organizations. The study was designed to evaluate the one-year risk of serious side effects among immunosuppressants and tumor necrosis factor inhibitors in patients with sarcoidosis. In over 13,800 patients receiving immunosuppressant agents, those who received mycophenolate mofetil had higher risks for inpatient hospitalization, critical care and mechanical ventilation, mortality, and infections compared to methotrexate use. Azathioprine use was associated with increased risk for mortality, hematologic toxicity, and infections compared to methotrexate. In over 3,900 patients receiving TNF inhibitors, there was a slightly higher risk of anemia, thrombocytopenia, and pneumonia, but lower risk of soft tissue infection in those receiving infliximab compared to those receiving adalimumab. These findings help to identify side effect profiles associated with immunosuppressant and TNF inhibitor use in people with severe sarcoidosis. Also in this section is an original research article that explores differential effects of antifibrotic treatment on outcome prediction via serial CRPM levels in idiopathic pulmonary fibrosis, and a chest narrative review of subclinical interstitial lung disease and rheumatoid arthritis focusing on early detection and management. Next is our education and clinical practice content area. Clinician perceptions of the July 2021 Veterans Health Administration nationwide inhaler formulary change from budesonide formoterol MDI to fluticasone salmeterol dry powder inhaler use are unknown. In this issue, Pierce and colleagues report findings from a cross-sectional survey of 511 respondents, including pulmonologists, pharmacists, and primary care providers, that was designed to present Veterans Health Administration clinician perspectives on the inhaler formulary change. 54.4% of respondents agreed that veterans were informed of the change in advance, while 24.7% considered the inhaler education provided to be effective. 75.5% of open-ended responses expressed a negative sentiment about the formulary change. 11.8% were neutral and 3.4% were positive. Themes included poor inhaler tolerance, concerns about worsening patient outcomes, and increased provider workload. These findings underscore the importance of timely clinician communication, patient education, and specialty engagement in future formulary transitions. Also in this section is an original research article describing serial MRI measures of short-term parenchymal changes in neonatal bronchopulmonary dysplasia, and a scoping review of evidence to support the U.S. FDA review of new medical technology in pulmonary, sleep, and critical care medicine between 2014 and 2024. Our pulmonary vascular content area is next. Current evidence supports risk-based treatment for pulmonary arterial hypertension. In this issue, Kahn and colleagues report findings from 1,019 patients with incident pulmonary arterial hypertension enrolled in the Pulmonary Hypertension Association registry to help identify current treatment patterns for people with newly diagnosed pulmonary arterial hypertension. 34% received initial monotherapy, 55% dual therapy, and 12% triple therapy. When monotherapy was prescribed, 25.1% of recipients were low risk, 31.3% intermediate risk, and 43.7% high risk. When dual therapy was prescribed, 35.7% of recipients were low risk, 26.5% intermediate risk, and 37.8% high risk. When triple therapy was prescribed, 31.9% of recipients were low risk, 28.3% were intermediate risk, and 39.8% were high risk. These findings highlight patterns of underutilization for those who are high risk and overuse of PAH therapies for those that are low risk in patients with newly diagnosed pulmonary arterial hypertension. Completing this section is an original research article that evaluates the pulmonary hypertension functional classification self-report measurement properties. Next is our sleep medicine content area. The association between dyspnea and obstructive sleep apnea remains uncertain. In this issue, Moreau and colleagues report findings from a prospective cohort of 1,200 participants from the general population, 42.9% of whom reported exertional dyspnea. The study was designed to determine if there is an association between exertional dyspnea and obstructive sleep apnea in the general population, and what polysomnographic obstructive sleep apnea-related measures associate with exertional dyspnea. There was a positive association between exertional dyspnea and an apnea-hypopnea index greater than 15, with an odds ratio of 1.57. With an AHI greater than 30, the odds ratio was 1.72. With moderate obstructive sleep apnea, the odds ratio was 1.6, and with severe obstructive sleep apnea, it was 2.25. Dyspnea was associated with the apnea-hypopnea index, respiratory disturbance index, respiratory pulse wave drop index, sleep apnea-specific pulse rate response, respiratory arousal index, and oxygen desaturation index 3%. These findings identify an association between exertional dyspnea and moderate and severe obstructive sleep apnea, potentially due to heightened autonomic and cortical responses to increased respiratory efforts. Also in this section is a research letter exploring geographical variations in continuous positive airway pressure termination rates in patients with obstructive sleep apnea, and a CHEST narrative review on real-world use of consumer sleep devices. Next is our thoracic oncology content area. Atelectasis during peripheral bronchoscopy can cause CT to body divergence, false positive radial probe images, and can obscure a target. In this issue, Boster and colleagues report findings from a randomized controlled study in 62 patients undergoing robotic bronchoscopy for lung nodules that were less than 3 centimeters and located in dependent lung zones. Patients were randomized to a lateral decubitus strategy or a ventilatory strategy to prevent atelectasis, otherwise called VESPA. The primary outcome was the development of atelectasis obscuring the target, with atelectasis detected with mobile cone beam CT imaging. No patients developed atelectasis obscuring the target in the lateral decubitus group, and 9, or 27.3%, did in the VESPA group. Tool and lesion was achieved in all of the patients in the lateral decubitus strategy group and in 72.7% in the VESPA group. The diagnostic yield on index biopsy was made in 86.2% in the lateral decubitus strategy group and 57.6% in the VESPA group. There were no differences in complications. These findings suggest that a lateral decubitus strategy is superior to a ventilatory strategy to prevent atelectasis from obscuring targets in patients with nodules in dependent areas and is associated with better procedural outcomes. Also in this section is an original research article that reports on the use of and outcomes related to intrapleural enzyme therapy for complicated parapneumonic effusion and empyema, as well as 2 research letters. The first on stereotactic body radiotherapy utilization trends for stage 1 non-small cell cancer, and the second, a National Health Interview Survey analysis of lung cancer screening in the United States in 2024. Completing this section is a How I Do It review on process improvement for clinical follow-up of incidental lung nodules. I encourage you to read our commentary series, where you'll find thoughtful pieces on preparing patients for life after lung transplant, inhaler training for patients with non-English language preference, and the use of incentive spirometry, as well as our humanities series, where you'll find an exhalations piece titled Fear as the Second Diagnosis. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all of the high-quality content available in this month's issue of CHEST. As always, I'm grateful to the authors of this work, reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the April issue.
Thanks for listening to the CHEST Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original CHEST Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.